Our next speaker is Electra Paskett, who is the Marion N. Rowley Professor of Cancer Research at The Ohio State University. I've known Electra for many years, and she has taken an incredibly scientific approach to better understanding how we provide care to our patients, where the gaps are, and whether interventions, in fact, make a difference or not. And so we've given her the weighty task of doing an overview, if you will, of the data that supports or not the concept of patient navigation. Harold's given us his own personal experience. Electra, I think, is going to give us an experience of others in this area. So, Electra, thank you.
Thank you very much, Larry. It's always a pleasure to follow Dr. Freeman, and it's really a pleasure to be acting out what he has described for us. So yes, I have been tasked with talking about the evidence base for navigation, and so what I'm going to do is review the scientific basis for patient navigation across the cancer continuum, and then lastly explore opportunities to generate additional evidence about patient navigation programs. So I have here at the bottom a figure of the cancer control continuum or cancer care continuum, and I am reiterating exactly what Dr. Freeman just mentioned, that there's the community piece. We have to bring the people to the door. We have to get them screened. And then the clinic piece where the navigator, traditional name on the navigator, takes over. And then the patient is released back out to the community in the survivorship phase for rehabilitation. And it's important for you to realize the phases at the bottom, because I'm going to refer to those through my presentation. And we have the community, and we also have the healthcare system. And the healthcare system sits in the community, but we have to remember the community that the patient lives in. So I'm going to start with a case presentation. These are true people. So first, Mrs. Jones is a 33-year-old black woman with a cervical abnormality on routine Pap test. Her physician recommended a colposcopy within 6 weeks. She has no other health issues. She's a beautiful woman, has 5-year-old twins. She's college educated, has a husband, and she's working. Mr. Smith, on the other hand, is a 51-year-old black man. He presented to his primary care provider with rectal bleeding and pain. His physician recommended colonoscopy as soon as possible. He has a history of mental health issues. He has no transportation, difficulty understanding instructions, works in a blue-collar job, and lives alone. So as I ask my medical students when I present these cases in Social Determinants of Health lecture, who returned for a follow-up, and I'm not going to make you wait till the end of the lecture, which is what I usually make them do. So Mr. Smith returned. And the reason he returned was because he had a navigator. He was a consented patient in the Patient Navigator Research Program. And Ms. Beverly, his navigator, worked with him for months, rescheduled his colonoscopy 3 times. She coached him to take the prep as instructed. And she actually drove him to the hospital and drove him home because he had nobody to take him. Didn't understand that he could take a vacation day to get his colonoscopy done and schedule it for a Monday so he could do the prep on Sunday. As you can see, she did a lot of phone calls to get him in. And guess what? He had a 5-centimeter polyp on that colonoscopy. So she prevented a cancer in this gentleman by not letting him be lost to follow up. And lastly, encouraged him and taught him how to be his own navigator. So does that make a difference? Does it make a difference to get people in for timely care, okay, which is one of the principles of navigation? This is a study that we published. One of my PhD students did this, looked at Medicaid patients and found that Medicaid patients who got in to start treatment for breast cancer before 60 days had a mortality difference. Okay? So it's a lot more than just touchy-feely stuff. Okay? This makes a difference in life and death. So the underlying premise of patient navigation then is that patient navigators will get the patients into the healthcare system ever in terms of getting screening or faster. And the abnormalities will be resolved or cancers will be treated earlier. And how they do that, as Dr. Freeman said, address barriers. That is the cornerstone of how a navigator works. They address barriers, and the barriers can be at the system level, at the provider level, or at the patient level, and those would include the social determinants of health. My heat is getting turned off. I'm getting kicked out of my apartment. That's what navigators take care of. I can't talk to my provider. Do you understand what your provider told you? What is a colposcopy? You know, the average woman doesn't know what a colposcopy is. Okay. And then system level barriers, in that we only send reminder letters for your appointments in English, but you only speak Spanish. Okay. Those are the types of barriers that occur. And if we do this, it will result in better morbidity and mortality. Mortality I just showed you. Quality of care and satisfaction, and costs. Cost to the healthcare system, right? So why do we need the scientific base for patient navigation? Why am I even giving this talk? And it's because we need these evidence. We need the evidence-based interventions to be implemented in clinics. That's how we operate. We implement evidence-based interventions. We also need evidence to assure reimbursement for these services. Yes, it's in the Affordable Care Act, but it doesn't mean that there's any way to pay for patient navigation, because there is no way to pay to reimburse for patient navigation right now. There is American College of Surgeons accreditation for requirement for patient navigation, but again, it's an unfunded mandate. And we don't have insurance reimbursement for patient navigation right now. There's no billing code. So we need this evidence to push for that. So what I'm going to talk about are some sources. The evidence before patient navigation research program, which will take me one slide. And then I'm going to talk a lot about patient navigation research program. And Dr. Freeman didn't mention, but he is really the impetus to starting that. When he was the director of the Center to Reduce Cancer Health Disparities at the National Cancer Institute, he started this. And so the bulk of the evidence for patient navigation comes from the patient navigation research program. And then after patient navigation research program, we're back to very few studies. And I'll talk a little bit about that. Okay, so before patient navigation research program, there were the data from randomized controlled trials, which we take as the gold standard, were extremely sparse. There were observational data, and observational data in every case supported patient navigation. Navigation was studied along some points of the cancer continuum, but not others. Mostly studied in terms of the screening and the abnormality, and few in treatment. And certain cancer sites did not receive any attention. The overwhelming cancer that was covered was breast cancer, and many of the other sites received no attention. And in addition, much of the work was qualitative. So not numbers, but really qualitative, observational, and really not numbers generated. So then we have the results from the Patient Navigator Research Program. So I'm going to very briefly tell you just a little bit about it and then go into the results. So Patient Navigation Research Program, as Dr. Freeman mentioned, started in 2004, and these were the sites that were funded. They were across the country, and you can see that they also included many different type of populations that suffered disparities. What we looked at in patient navigation, again, this is the continuum, cancer care continuum. The first results I'm going to show you are the results looking at, one, somebody had an abnormal screen, and we included cervical, breast, and colorectal in this study to a diagnosis. So we call that affectionately T1. So this was defined as the date of the abnormal screen to the date of diagnostic resolution, being you are okay or you have a cancer. That was what T1 was designed. And each of the PNRP, Patient Navigation Research Program sites, had their own study design. Some were cluster randomized designs, some were pre-post designs. But we put them all together and did a prospective meta-analysis, and Karen Freund led this analysis. And our outcomes for T1 were time to resolution, as well as the percent that were resolved within these two time limits, 0 to 90 days and 91 to 365 days. So I just wanted to show you the sample size. So this is over 10,000 people that were enrolled across the sites. And again, the majority were breast, but we had a good number in cervical, a few in colorectal, and we also had a couple of sites that recruited for prostate. So we had not only women, but we had men in this. So here are some demographics, and you can see in the red box there, the majority were non-white participants in this study. Over 70% were either public or uninsured. And again, the majority were breast. But very few studies will you see this description in demographics where it's a majority non-white and poor. And this is the group that we included in PNRP. So let me orient you here. This is the meta-analysis, and this is looking at those who achieved diagnostic resolution in the second group, the 91 to 365 days. And the solid bar at 1 is no change, and anything that is on the right side favors navigation, anything on the left side favors the control. And virtually all of these sites, so these were done by site, by cancer type, each of these individual analyses, and you can show virtually everything favored navigation, and the overall at the bottom favors navigation in terms of getting people in for timely resolution. So the second outcome was starting of treatment. So once somebody's diagnosed with cancer, it's important to start treatment quickly. So that was what we called T2. And if I could just draw your attention to, again, the last column. This is, again, in the last time period, 91 to 365 days. The first row is a diagnostic phase, which I just showed you. The second row is the treatment phase, and we had identical effect almost for bringing people in, making sure people got in for treatment as well as diagnosis. So you might then say, well, who benefits from navigation? Because in real life, we have limited resources in order to navigate. So who would you navigate? Who would you choose to navigate? And so we looked at this from a variety of perspectives. You can say, well, I will navigate people who are at risk of loss to follow-up, because that's actually what navigation did, was they found people who would be a loss to follow-up and got them into the system. Or you might say, since navigation works through barriers, I can find out who has a barrier. And at our site, we found about a third of patients had barriers. That's not similar to every other site or every population. But you might say, well, I'm only going to navigate people who probably have a barrier. Or you might say, I'm going to navigate people who I know will get the most help of navigation. Whichever way you choose, you can figure out perhaps who benefits from navigation. So let's look at the first one. Who is at risk for delay or loss to follow-up? Loss to follow-up meaning they fall through the cracks. And this happens because most physicians, healthcare providers, you only see who comes in your office. You don't see the denominator in terms of who's supposed to come in to your office. So navigation can make sure that everybody who's supposed to come in comes in. And indeed we did. We found that. So who's at risk of being lost to follow-up? And these are what we found. Those with more comorbidities, those with barriers to care. And barriers to care. Isn't that what a navigator does, is address barriers to care? So again, there's a validation here of what the navigator does. Low income, unemployed, less education, renters, non-married, and dependents. These, again, are social determinants of health, the poor, etc. But let's look at this barriers to care. And again, these are data from Patient Navigator Research Program, but they show you that the top line, the blue line, are those people with no barriers, and they resolve faster. They come in faster. does that make sense? Of course it makes sense. And the ones with, and these are type of barriers. So the social barriers, the patients with the social barriers were the slowest to come in to resolve. So let's look at the second suggestion, which is who reports a barrier. And these are data just from our Ohio data. And we found that those who are more likely to report a barrier are non-white, lower educated, unemployed, retired, again, low income, and uninsured, and have comorbidities. We're getting a pattern here in terms of who needs this help. And then who does patient navigation help the most? And these are secondary analyses from the Patient Navigation Research Program. And let me, if you remember how I oriented you, anything under 1 favors the control and over 1 favors navigation. So this is the point of this slide is that navigation eliminated disparities by income. So the lower income in the middle column, they are less likely to resolve. But navigation, in the navigation arm, you don't see that. So navigation eliminated the disparity of follow-up in the lowest income group. So the same thing here, navigation eliminated disparities by employment. You can see in the far column, those in the navigated arm that work full-time were more likely to come in. But in the unemployed, the middle column, they are less likely to come in the control arm, and navigation eliminated that disparity, as you can see in the far right column. And then this is the impact of navigation for patients with other comorbidities. And again, these are all participants that had 2+ or major comorbidities. And the navigation arm is in the red, and they came in faster. They resolved faster. So again, navigation addressed the most at-risk patients. So what did Patient Navigation Research Program show us? It demonstrated that in a large, I would say 10,000 patients is a large, diverse population, patient navigation can reduce delays to receiving follow-up care for cancer abnormalities, reduce delays in starting cancer treatment, reduce those lost to follow-up. And these are probably the most important patients. Patient navigation found 18 to 20% of those who would have been lost. Never come back to the system. Never, ever come back to the system. When we would have seen them, they would have been stage 4 cancers, the patients Dr. Freeman talked about. And patient navigation also helped those most in need, as I showed you on those last slides, the unemployed, those with most comorbidities, and the low income. And those who need patient navigation are those at most risk for loss or delay, poorer, sicker, and have more barriers to care. They're exactly the ones that patient navigation can help. So, since patient navigation, the evidence, we published a paper, again, looking at the evidence from 2010 through 2015, and this was solely in women's cancers. And we included 29 articles that met our inclusion criteria, and 5 others that included other cancers in men, so 5 in colorectal and 1 in lung. And the areas included where navigation was done was screening for breast and cervical cancer, diagnostic resolution, and then after diagnosis, so treatment care. Various study designs were used. However, again, few were randomized controlled trials. And still, there is an overwhelming focus on breast cancer. However, the majority demonstrated patient navigation to be effective in screening, time to diagnosis and treatment, adherence to care, quality of life, receipt of quality of care, improved knowledge, and communication with the healthcare team. So again, we have some positive evidence. There's more recent evidence. Many of you might have seen these 2 papers, and I believe we are having some speakers from these studies later in this program. In colorectal cancer screening, we have increased screening with decision aid in a vulnerable population. And then costs and healthcare use in the Medicaid population with cancer. The outcomes were costs, ED visits, hospitalizations, and ICU stays all declined in navigated versus non-navigated controls. It was an observational study, but very strong evidence. And the last article quoted saving over $19 million in healthcare costs. So lastly, I want to talk about opportunities to generate additional evidence. So where are the gaps in evidence? And I think the gaps in evidence are, first of all, we need a more comprehensive patient population. Across, again, if you look at the cancer continuum, we have very few studies in the post-treatment setting, and we have very few studies even in the treatment setting, as well as virtually no studies in the palliative care setting. So those are big holes. Secondly, a wider spectrum of cancers. This is the third time I'm saying this, is that there's an overwhelming focus on breast cancer. And I don't mean to pick out breast cancer negatively, but we need to add to that evidence that we have in breast cancer. We need to think about innovative study designs. Randomized controlled trials, although they are the gold standard and recognized by many, they are limited due to funding and their limited duration. Implementation science studies offer many solutions, and they offer some solutions in terms of you are able to do your navigation or provide navigation for a wider audience versus in the randomized control trial, we usually only have people who consent. And consent, I don't want this to be taken wrong because I follow consent procedures, but at times consent can be a real big turnoff for the populations that need help the most. And mostly it's our fault because we have 25-page consent documents, but that's another discussion. And we need to expand our metrics, all right? We don't just need to look at what I've shown you. We need to look at things like missed appointments, satisfaction with care, mortality, costs in the light of return on investment. So if I say missed appointments, those of you who are administrators in the audience, does that go deficit, deficit, deficit when I say missed appointments for a colonoscopy? Does that go ka-ching, ka-ching the wrong way? All right. So keep that in mind for what I'm going to talk about in just a half a second. And we need to find ways to sustain patient navigation using different models and payment structures. So I'm going to give you an example of what we are currently doing. We call our patient navigation program the Wayfinder program. And we have used multiple sources of funding. We have some cancer center institutional funding for our navigators. We have a Komen grant that we have a funded patient navigator at the breast center. The need was so great at the breast center that our navigators can only navigate Medicaid and minority patients because we just don't have the bandwidth. We don't have enough staff to meet the need. And we just recently got an upper payment limit grant funded by the Wexner Medical Center and 4 clinics. And our goals are to look at no-show and cancellation rates and to increase adherence to preventive services in the Medicaid population and to assess the cost. So I'm going to show you some unpublished data. These are just from our first 6 months. So these are the no-show rates, and you can see, let's look at the colposcopy rate. You can see it was baseline 45% no-show. We've gotten it down to 27%. But look at the endoscopy. This is for colonoscopy, 32% no-show rate. We've got it to 6.1%. And this is in the Medicaid populations and primary care clinics. We are looking to find people who need top-line cervical screening, second mammogram. We've had a 45% change in terms of those overdue for a mammogram, and colon cancer screening. So Do we have enough evidence to say that patient navigation works? Yes, in most of the cancer continuum, in many populations, and several outcomes. What do we need? Innovative study designs in real-world setting using implementation science. We need to expand the populations. We need to use additional metrics, cost and return on investment. We're going to do that. We just haven't gotten to that point yet because we just have 6 months of data that I showed you. Focus on sustainability. How are we going to do that? Make the business case. And then policy regarding patient navigation and reimbursement. So thank you very much for your attention.
Thank you very much, Electra. That was both informative and, again, I think helps to orient us in where we should go over the next day and a half.